our thought process is that 20% of Americans live in rural area, and rural residents have 30% higher stroke incidence and 30% higher stroke mortality. We want to find out, and there has been reports that rural patients are less likely to be treated with thrombolytic treatment. We want to find out whether this lack of treatment occur because of delayed hospital arrival or because hospitals are not providing the care. And using guideline database, we can also study their other care perspective. For example, the secondary stroke prevention that can affect the stroke rates. And these metrics are all captured in guideline stroke. So we compared rural hospitals and urban hospitals, the patients treated in these two groups of hospitals in terms of thrombolytic rates among patients who arrived within the 4.5-hour thrombolytic time window and the door-to-needle times, and also the secondary stroke prevention metrics. And we found that different from our racial and ethnicity study, we found that rural hospitals provide less thrombolytic treatment for patients who arrived within the 4.5 hours, and their door-to-needle times are longer. So we divided the rural hospitals into rural stroke centers versus rural non-stroke centers. And also we divided urban hospitals into these stroke center versus non-stroke centers. We found that rural hospitals, among those who arrived within 4.5 hours, 1 in every 9 patients at the rural stroke centers, and 1 in every 14 patients at the rural non-stroke centers received thrombolysis, compared to 1 in 6 patients at the urban hospitals. And the door-to-needle times are longer at the rural stroke centers for all the guideline recommended door-to-needle times within 60 minutes, within 45 minutes, and within 30 minutes. But there is a difference between the stroke center and the non-stroke center. Rural stroke centers are inferior to urban stroke centers in thrombolytic treatment rate and door-to-needle times, but they have comparable performance in secondary stroke prevention metrics, including giving antiplatelet medications or statin treatment or smoking cessation. Rural stroke centers are comparable to urban stroke centers, but the rural non-stroke centers have less performance than the rural stroke centers in both thrombolytic treatment rate and door-to-needle times, as well as the secondary stroke prevention metrics. And the rural-urban disparity was the greatest without adjusting for any risk factors, and attenuated after adjusting for hospital factors, and further attenuated after adjusting for county-level socioeconomic factors. So from the rural-urban disparity study, we feel that the disparity mainly lays in the hospitals. And further resources and targeted initiatives are essential to improve thrombolytic treatment rate and speed out treatment for our rural hospitals, as well as secondary stroke prevention in rural non-stroke centers.